All right. Welcome, folks, to the NeuroFlow webinar about using virtual care to cope with coronavirus. We're just going to wait another minute or so before getting started to let a few more people enter the room, but thanks for joining. All right, so let's go ahead and get started then. Just a few housekeeping notes. We will be sharing these materials after the webinar, so we'll send that out to all attendees. And please, if you have questions at any time during the webinar, you can submit them, and we will address those in the Q&A session in the last 15 minutes or so. So excited to talk with everyone today. Obviously, living in very different times right now, and we're all talking about virtual care and telehealth. But a little bit what we want to talk about today is how telehealth is not enough on its own. It's a very important step, but virtual care more holistically is a whole nother level. We also want to talk about how everything that's going on with coronavirus and COVID-19 impacts people's mental health. Also unpack some of the misinformation and myths around coronavirus, and talk about some different strategies to respond, what we're seeing out in the industry. And then at the very end, we'll talk a little bit about some of the resources that NeuroFlow is offering, but this is not going to be a commercial. We're really excited to talk about what we're seeing, in the trenches every day, and we'll kick it off. So very briefly, just want to go through some introductions. I'm the Chief Operating Officer, founder of NeuroFlow. My name is Adam Pardis. I was a researcher before founding the company, and have served on numerous National Science Foundation grant review panels. And I'll pass it off to Matt to introduce himself.
Sure. Thanks, everybody. Really excited that you all joined us today. So my name is Matt McClett. I'm the head of clinical operations here at NeuroFlow. So I head both of our clinical teams and our health policy teams here in the company. I'm a board certified registered nurse by background. I served 6 years in the Army, had the opportunity to lead teams both treating combat trauma at Walter Reed, and also worked in inpatient behavioral health at Fort Hood, where I had the opportunity to lead that unit there. I then shifted gears a little bit, went into public health. So I worked in public health policy for a number of years, really looking at how do we connect together the researchers, policymakers, and clinicians in a way where we can really advance evidence-based practices at that policy level. And really the focus there of my research was in substance use and how to address the opioid epidemic. I've also founded and led nonprofits. So I definitely identify as a nonprofit leader. And today, leading the ClinOps team here at NeuroFlow, looking at innovative ways to both increase engagement and access to behavioral health resources.
Thanks, Matt. This is Mike Consuelos. I'm the principal at MJC Solutions, which is a veteran-owned small business who provides healthcare consulting, advisory services to the healthcare sector, and also executive coaching. And I'm happy to work with NeuroFlow as they continue to help tackle our behavioral health issues across this country. I have about 20 years of experience in emergency preparedness, specifically around pandemic response. And in that, business continuity is one of my sort of subspecialties in helping not just healthcare organizations, but other small businesses maintain business operations during pandemics. I've also had some experience in policy development at the Hospital and Health System Association of Pennsylvania, and have worked with several large clinically integrated networks in Pennsylvania, and former, like I said, Army veteran, and was a physician in the Army. So I am very happy to be here to talk about how COVID-19 is affecting the population here in the United States and in fact around the world. So I guess we'll start with the first slide. Yes, thank you. So this slide really just shows us where we are most recently around the impact of depression and anxiety across the United States, and really that 1 in 5 folks have some sort of behavioral health disorder, and the impact of the cost of care of those individuals. And if we look at not just behavioral health, but also behavioral health comorbidities, those two things really crank up the cost of care across the United States. If you look at the map right now, if you look at, for example, go to the Johns Hopkins dashboard for COVID, a lot of the hotspots for behavioral health, unfortunately, are the same hotspots that we're having in this current pandemic, which really is concerning because as we ramp up our medical facilities to treat the most ill and screen those who are concerned about COVID-19, we're also trying to treat our communities for behavioral health problems. Next slide, please. Thank you. So as we think about the effect of coronavirus on the healthcare system, you may have gotten information from your local, if you're a health system, you're already doing this, you're a payer, you're working with your providers, or if just your physician or health system in your area, you're already getting emails and alerts and news flashes about how the healthcare system is being impacted with the sort of shelter in place or the decrease of non-essential travel. And so now we're having patients who are missing their appointments, their regularly scheduled appointments. We're also seeing emergency departments being overutilized with the worried well, really. And really for the COVID-19, as we get more and more data, clearly older individuals with comorbidities seem to have the greatest risk. So data just came out of Italy today. The average age of those who have unfortunately died over the past couple of weeks is about 80.5 years old, and about 99% of those had at least one medical condition, which obviously makes sense for folks who are of that age. A lot of them will have comorbid health conditions. That clearly is an important piece. That is not to say that individuals aren't also younger individuals aren't also being affected. So it's really running the gamut. So as this slide shows, where does this leave us for now in the future is that we have a real increased utilization of healthcare resources. And at the same time, we have the potential for leaving the folks who have behavioral health problems kind of alone in the dark, but also the social isolation that is occurring is making that worse. And on top of that, we have a workforce that's also going to be more and more stressed and burned out. So we really have the makings of not just a viral infection pandemic, we also have the possibilities for a behavioral health impact across the board. So
actually, it brings up a good point, Dr. Steve, if you don't mind sharing a little bit more about how you see this impacting the physicians, the nurses. There's frontline staff that are still going into these health systems providing care. What do you think the mental health impact will be on those personnel?
Yeah, thanks, Adam. Yeah, thanks. I kind of blew through past that. Yep, absolutely. As I'm working with several clients of large systems, they're already starting to see some evidence of burnout. And so let me just explain that a little bit more. It's not just the hours of the day that the individuals are working in healthcare at the hospital, it's what's happening at home. So you have the impact of children who no longer are in school, potentially elderly family members who are also potentially at risk. So there's a higher level of anxiety that will impact that, and then just the long hours, and with the decreased availability for PPE or personal protection equipment, that is also increasing anxiety. That we have stories now coming out of Italy where doctors who have been treating patients with COVID-19 are now dying. So that is obviously a concern for all of us. So I think, next slide, so we're hearing currently more and more usage for telemedicine. And in fact, Seema Verma just released information late yesterday about allowing providers to use basically what would be considered just a few weeks ago non-HIPAA compliant ways of interacting. So now FaceTime, Skype, this webinar kind of type of modem is now going to be allowed, or at least relaxed for patients to contact their physicians or other healthcare providers. And I think that's an important piece. And I don't know, Matt, do you want to move on and talk about more about telemedicine and adoption the response?
Yeah, I mean, the only thing I want to throw out there for you guys is that, CMS has been putting out just a lot of resources over the last few days. So I certainly encourage you guys and to check out the fact sheets that they've addressed. They're really looking to expand the telehealth waivers that are out there, really broadening the opportunities for telehealth, making those payments really comparable to in-person visits, and even things like allowing providers to practice over state lines. So there's a lot of opportunities out there, and just let us know. We're certainly trying to keep up the best we can with the news as fast as it moves. We're not going to go into specific coding and such today, but please feel free to reach out, and we're happy to discuss ways to make sure that you guys are still delivering the care and getting reimbursed for those activities.
How do you guys think that'll be sustained after this initial wave? Obviously, right now, a lot of things are being relaxed. Telehealth is being promoted. Do you think we move to more, will telehealth continue to be maintained, or will it wane back down? It's clearly an important inflection point, but unclear where the line will go after this.
Yeah, I'll take the first stab at it if you don't mind, Dr. C. I think it's a mixed bag. Because certainly this is where the direction of healthcare is going, is increasing to increase the adoption of telehealth throughout the country. But when we talk about practicing over state lines, this has traditionally been a state regulation, right? So a lot of these things that the government is now coming in and trying to make this a lot easier to be able to get access to not just mental health care, but to be able to treat coronavirus. They're taking over some of this traditionally state regulations. But when we look at where the trajectory of telehealth is going, right, this is the wave of the future. So we'll see how much they actually end up relaxing back or not. I think, by all means, it'll probably be quite the mixed bag.
Yeah, I would agree with that. I mean, right now, over the past couple of years, several states have gotten hung up on sort of interstate or between state telehealth regulations. We could spend hours talking about the political ramifications of allowing physicians to practice across state lines. It's kind of an interesting situation, but I think that the cat's out of the bag on this one, and I think especially on the payer side, where some of these questions sort of may have come up as we're using this and we're potentially decreasing or impacting the cost of care. I think there may be a better case going forward to continue to use telehealth, remote patient monitoring, obviously building into that, and reducing overall utilization. The other thing is acceptance by patients, right? So that's the other side of the equation. And the question is, how well will patients accept this? And I think if we have a consumer push saying this was much more convenient, timely, the next time I need to come in for a refill, I'm doing fine. Can I weigh on my fully integrated scale and send you my blood sugars and my blood pressures via my smart devices? Do I really need to come into the hospital or the provider's office space? I think it's also going to be, part of the conversation is going to be from the consumer, and then overall, again, the regulatory process. I think now as we relax things like interstate licensure, I'm hoping that we are able to fast track that going into the future. So I think we're ready for the next slide, if that was, yeah. So, I think what we're seeing here is we're continuing to sort of just that this slide here kind of wraps up what we've been talking about here a little bit, is that anxiety, fear, and stress is going to make behavioral health, mental health disorders even worse. The social isolation is also a huge piece. AARP a couple of years ago published some data that shows that seniors who suffer from social isolation have an extra $134 per year of increased cost of care, which doesn't seem a whole lot, but when you consider that across millions of people over the age of 65, that is a huge hit. It's actually more expensive. Social isolation is actually more expensive to the system than just arthritis. So that was an interesting piece. And then again, the social stigma piece, as we started to have more and more problems during this pandemic, the question is, as people self-identify or potentially don't want to identify themselves and go to receive care, will we see more and more problems around that? Matt, what do you think about that? That's a lot of your area of expertise.
Yeah, we can kind of get into, I think the next slide, actually, maybe this is a great segue. I think a lot of where this anxiety is coming from is the uncertainty, right? And with the uncertainty becomes a lot of misinformation. Had a great example today. I had my mom send me an article from Yahoo News, which has traditionally been a very reliable source, right? I mean, even I think NBC or somebody else was also sharing this story about ibuprofen use for coronavirus. And she was kind of half joking with me because, Dr. C can probably attest, ibuprofen and RE medicine is kind of a running joke, right? No matter what you have, you give 800 milligrams of ibuprofen for it. And what this article basically was sharing is that the World Health Organization is now advising against using ibuprofen. And the interesting thing was that this was not true. So I immediately went to the World Health Organization's Twitter account, and the very first thing on their Twitter page was actually saying, no, we're not advising against using ibuprofen. So even reliable news sources traditionally now, we really need to double check and see where those sources are coming from to find that true source of truth. Sorry, I'm hearing some feedback in my own voice, and that always creeps me out. So it's really important to stay up to date with what's going on, checking in with the CDC, checking in with some of these sources we listed below that you'll have available to you in order to really know where that source of truth is to go on information. Because when we're able to teach and help people understand about the coronavirus, right, we're not going to lead to more panic. We're actually going to lead them to feeling much more in control of the situation. When they understand how to protect themselves, how to do these preventative measures, and not just wearing a mask everywhere they go, that's going to reduce the risk of anxiety disorder development and such while they're at home alone, just concerned and worried about what's going on. It's also really important to make sure that you identify when you do see this misinformation happening. That might mean responding to your parents or kids' Facebook posts just to say, hey, you should really check with the sources here, and provide that information to the ones that are loved ones, but also to your patients, right? How do you get that information out to them? And that's something we're working on. We can talk a little bit more toward the end of the webinar about some of the sources we're trying to make available for our patients and for yours, to make sure they know where they can go to get this information. Because if we have some understanding of what's going on, they're going to feel more in control of the situation, and that's going to help with their anxiety. I'll pause there. You guys have anything?
Yeah, I think that's a big piece of the virtual care side of things, because people are used to going to their doctor as their trusted source of information when it comes to something like this. And, a lot of times it's not happening face to face anymore, in person at least. And even from a telehealth standpoint, you're seeing one patient at a time, even if it's over video. So how do you, as a physician or as a healthcare system, share this like legitimate information with your patients in a broader and quick sense? I think is a challenge that we've been hearing from people.
Right. And if you go to the next slide, I think a particular population that we should really think about too is children. And how do we actually educate children about what's going on? Because this is not just concerning to everybody at home, but kids are home from school, right? And they understand that stuff's going on. They understand that this situation can be scary. So there's a lot of resources out there about how to talk to kids about the coronavirus. And when you as a parent learn and understand more, that also can help you. So it's really important to think about how you want to talk to your kids and anybody else that lives in your home. Additionally, this is a great opportunity to talk about stuff that would help at any time. So things like self-care, right? What can you do for yourself? You might have to get creative. If you're somebody that's going to yoga three times a week, and you generally have a great way to take care of yourself in the normal world, if you will, this is a different time. So how can you still be able to practice that yoga at home? Is anybody offering Zoom sessions? Can you look at YouTube? For me, it's going for runs. I'm not restricted to go for a run right now, right? Understanding that doesn't mean you can't go outside for walks. There are still opportunities there to take care of yourself. This might be a great time to learn mindfulness, right? So how can we take care of ourselves and be able to educate not just about what's going on around COVID-19, but also understand about how do we take care of ourselves now in this new homebound environment that we're living in. The next thing I really want to hit on is understanding that we really need to find ways to better assess and monitor this patient population, right? We're going to be having increased volume of patients coming to us, either with questions or that are sick. So that is just because you're at home doesn't mean you're not going to break your leg or have all these different issues that happen on a normal daily basis are still going to occur throughout however long we're homebound. So how do we really assess and identify which patients we need to take care of first and prioritize? It's really a triage type model we need to consider. So when we can use remote monitoring, we touched on diabetes and monitoring blood sugar. The same can be done with mental health. So looking at things like using validated rating scales and such to really help identify which patients do I need to see first, and utilizing different methodologies now that you may not have considered before, because this is a new time and we really need innovative approaches. I also just want to touch on that, throughout all of this, we're going to have to still be care providers. And even if your specialty is not infectious disease, we know that there's a big relationship between mental health and physical health. So when people have mental illness, we know that outcomes get worse in things like diabetes and blood pressure. So how are we going to be able to address the demand of worsening patient outcomes, as well as maybe these new comorbid issues that were not present just a couple months ago? So being able and ready to deliver that care, and really thinking about how do we triage and take care of those patients that are most acute, is something we all really need to consider in the medical community. Go to the next slide.
Dr. C, while we're doing that, what strategies have you seen clients of yours implement, or previous systems that you've worked with, to address some of those needs? Because they're not new problems. I think they're worsened now, given the environment we're in. But they are problems that existed 2 weeks ago, 2 months ago.
Yeah, no, I think Matt covered a lot of that already. So I think that there's, the question will be, as we become more and more virtual and we're more reliant on these different technologies, how that will continue to speed up it's sort of, I guess, I had one person who, as we were having this conversation around businesses and business continuity, there's gonna be some creative destruction of how we used to do some of this work. So I think that, I don't want to take up more time, but I think that there's very likely, you're right, we probably should have managed this better in the past, and I think that there's the opportunities for organizations to rethink how they're addressing behavioral health within their organizations and within their patient population. One of my clients, when I asked them about how they're assessing stress and burnout in their organization, they said, well, we reminded everybody that they have an EAP program. I said, well, okay, I'm curious how you think that's going to work. And so we started talking a little more deeply about how there's, how this new normal and social isolation is really a problem. I think that, having people think creatively and using teleservices, conference services, is going to help. And the other piece I guess I want to talk about also is that the workforce itself, who's at home, maybe the direct care providers, but people who are in healthcare and payer systems who now have to work remotely, it's a whole new set of challenges for them. Let's forget about behavioral health altogether. It's a whole new set of challenges to be socially isolated and to work from home when your kids are also there. It's a lot of distractions. How do you set up boundaries? I'm right now, as I'm a solopreneur. I'm sort of doing my own thing. I have to have really good boundaries where my work stops and where my family time starts. So there's a lot of hygiene, sort of mental health hygiene and boundaries that need to be established.
For sure. Yeah, and 2 weeks ago, I really directed my team to essentially drop what we were doing and really start focusing on COVID-19 and how we can not just help our customers, but help the community. Because this is going to be an all hands on deck approach if we want to address the number of concerns that are going to be arising and continuing to arise as things get worse in our country. And one thing we did was make a publicly available website, which anybody can go to and check out some of the resources. We're going to be continuously updating this website with where you can go to both educate your patients, educate yourself, and at least feel some sense of some truth, right? And I keep coming back to that, a sense of where is the source of truth where you can go. And we want to help you with that. So of course, all of the CDC and Johns Hopkins resources pages are all on here. So at least there's one website you can go to get to them all. And you can see there on the left some of the areas we're particularly focused on in providing some patient education materials. But we'll keep this up for you guys, and we're going to continue to keep updating it. Another thing that we've done for our customers is we developed what we call a template. So for those of you who don't know about NeuroFlow and our actual platform, template is a module. It's a curriculum for our patients. And in this case, we created a coronavirus template to not just help with the education around the coronavirus, but to help with the mental health concerns that we expect to arise with the coronavirus. Another thing we're doing is we are prioritizing a loneliness scale so that we can really help you as a provider and help patients themselves identify, who is really at risk with this ultimate social determinant of loneliness in their home. We're also prioritizing doing a provider burnout education. So that's something that we're working on this week. Is what we are hearing from our customers is that it's not just about our patients, it's about us. So how do we help our providers in our network to feel like they can handle this? Because you guys have the technical skills, I have no doubt, to address this, but it's going to be a long road ahead. So how do we get you guys the resources you need in order to cope through this? And then finally, another thing that we're always here and available to do is just be consultants for you guys. We very much identify as being thought leaders in this space. And when it comes to telehealth and understanding, where are the reimbursement and other opportunities, we want to be a resource to you. So after this webinar, please feel free to reach out to us. We'd love to start a conversation with you about ways we can help, or at least give you some guidance of where you can go. Because we all need to you need to find ways to make sure that you're getting reimbursed for these services as well, because they're out there, and they're out there because there is value in delivering these services. The next slide.
Matt, do you want to share a little bit about the risk assessment as well?
Yep, exactly. And the final piece of what we're really putting together is a COVID-19 risk assessment. So I'm sure you guys have started to see that testing is not widely available for COVID-19. And right now, the CDC guidance on who should be tested is quite limited. So we really want to help our providers identify who should really be going and seeking for treatment right now. Because we can imagine that call volume is only increasing as people get concerned when they have cold symptoms, of a cough that could very well be COVID-19. So what we are doing is putting together this assessment for clinical partners. We're going to have a free version as well, where people can go through, self-assess, and depending on the level of assessment with our clinical partner, it'll direct where they should be going for help. We're also going to include an anxiety screening within this assessment so that we can really help and identify how is anxiety playing a part along with COVID-19. And what's going to happen is those that screen positively are going to be sent to the proper resources. So whether that's their healthcare provider or state health department, but maybe not more importantly, but certainly just as important is those that screen negative, we're going to make sure that they have the tools and resources they need to manage their anxiety and get the information they need about the coronavirus. So I think that's certainly what's going to be very unique about our tool, is that we're going to guide those that are negative to resources as well. And I think that's really important and can't be overlooked.
Yeah, and just to reiterate on that, like Matt said, there's a version of this that's available at no cost. This is a resource to the community. We feel like as a digital health company, we have to be doing what we can, given the tools that we have, to support our communities, our healthcare providers, and the patients that struggle with anxiety. And really, what we've heard, the initial feedback on this from our clients, whether they're independent medical practices, larger health systems or organizations, is that they have people coming to them, even if they're a pain management doctor. They have patients coming to them saying, I'm anxious about this. I don't know if I should get tested. You're my doctor, help me. And a lot of cases, people feel ill-equipped right now to do that effectively, which is why we've developed this so that they have, like Matt was saying, that source of truth to be able to say, go here. This is going to be quality information, all evidence-based. Additionally, there's going to be resources for you, because I know this is tough to manage, and we're all trying to figure out how to adjust and how to cope. So being able to do that all in one place, I think is really key, because we're really just at the tip of the iceberg when it comes to the impact that COVID-19 is going to have on behavioral health of our entire country. So before we wrap up with Q&A, again, please submit any questions that you have. I just want to give a very high-level overview of what our standard platform includes, because I think as things stabilize, going beyond, again, these telehealth visits, beyond the video visits, we're going to have to work together on ways to engage our population remotely, to assess them remotely, and to provide them with the resources that they need in their everyday lives. So what we've built are a suite of tools to help achieve all of those outcomes. We can reach people where they are and use technology as a way to augment and extend clinical care, not replace it. For all the things that we were talking about, Matt was talking about self-care. It's one thing to say that once and say, these are things you need to be doing, but then life happens, especially when you're working fully remote and there's so much going on. It's easy to get lost in it. So a lot of what we do is around the sustained engagement through different nudges and behavioral economics and different tactics to really keep those people engaged so that we can give them the resources they need, help them actually drive that behavior change, and then distill that information and feed it back to the care team. Just to give you a sneak peek of what that looks like, this is our mobile app that patients use. There's tens of thousands of patients across the country using this right now. Has different types of educational resources. These can be very easily customized by your organization. We've already built in, like Matt said, a lot of resources around COVID-19, around social isolation, and it's really easy to get signed up and just a great resource to be able to offer to patients. And then the last slide here before we go into the Q&A is again thinking about the utilization management side of things, because this is going to be a bigger and bigger issue. This was already an issue, which is why we developed the platform, and I think now it's just going to be so much more important because not everyone needs the same level of care. Not everyone needs a very high level of care, and there's additional exposure at that high level of care, and there's limited resources. So how can we best allocate resources? Well, it comes from assessment. We need to understand the severity of the population so that we can support them and identify who does need to see a clinical provider, who needs a telehealth visit, who can use self-management resources alone. So these are all the types of things that we think about on a day-to-day basis. Matt's team works on, and if this is of interest to your organization, happy to discuss more. So moving into the Q&A now, as a reminder, all materials and recording of this will be sent to registrants. I did see one question come in around provision of guidance around the provision of suicide-specific care via telehealth. Is that something, Matt or Dr. C? I'll leave to either of you to chat about that a bit.
Yeah, I can certainly at least start us out. There are absolutely evidence-based approaches we could be using telehealth for. There's generally about 3 widely accepted suicide intervention techniques. So as long as you're following those evidence-based guidelines, so using things like CBT and CAMS and GBT, to the model and to fidelity, then there absolutely is no reason that we can't be doing the same thing we'd be doing in person over telehealth. And just for example, things the CAMS model, a lot of what it is based on is identifying protective factors. So what is going to stop somebody from completing suicide, and really finding ways to emphasize those. While identifying the risk factors and risks that could lead to somebody completing suicide, and finding ways to mitigate those. So that could mean finding ways to remove firearms from the house and the such. But there's absolutely no reason that we can't use telehealth as a way to intervene during a crisis situation. And I should note that I just found some interesting research from the crisis text line, who is hard at work. So 741-741, if you ever need to direct anybody to the crisis text line, you just text home to 741-741. And they are finding a huge jump, particularly in people that are mentioning the word virus. So they put that in as a keyword and done some research and found I forgot what it was, but something like a tenfold increase in people that are having concerns over illness and sickness. So we know that this is having an impact on crisis situations.
Yeah, I have nothing else to add. I mean, the only thing I was going to add, right, was what Matt said at the very end. I think the 741 is a great tool, especially if there's a question about stigma, and again, also in the social isolation time where people are maybe afraid to do anything in person for whatever reason. That's a great resource. So I'll double echo that one.
Another question we touched on this a little bit, but they were interested in hearing more. Do you think some of these updated legislations will change back after coronavirus?
Yeah, I'll start with that since I just finished. So I think what I said before is I think that there's the walls are coming down on some of the, this is both the cross-state licensure issue, the telehealth, a couple other things that are coming out. Some of the just some of the FDA regulations. I know it's to keep people safe, but it does create cost and unnecessary burden on those trying to deliver telehealth, to practice medicine across state lines, and to have medications and vaccines approved by the FDA. I think that they're there for good reasons, but they're also, I know it because of my experience in policymaking, there's also some interests in maintaining what I would call market controls, right? So if so crossing state lines is going to create, for example, with licensure and telehealth, I know one of the questions always comes up is the teledoc type programs, and then a lot of times the state medical societies are trying to keep physicians based on computers from other states of stealing their patients and those kind of things. So it's a hairy political issue, but my hope personally, having done the work in the past, is that clear minds will see that, especially in a case like this, we're actually delaying care to individuals because we're trying to bring down walls that don't exactly make sense. If we keep those walls down, we will reduce the cost of care. We will allow care to be more easily done across state lines. And when the next time this happens, we're not going back to redo what we just did. It's already set up.
Yeah, I'd say it's definitely much harder now, right? Once you give an inch, it's harder to take that back in policy. That's just kind of a general rule of thumb. And I'd also say, if this is something that's concerning to you, I would reach out to your professional organizations, reach out to your policymakers, and let them know you don't want that to happen. I think now is the time to make sure that you get your voice heard, so that this lax in regulations, so that we can practice medicine over telehealth, can be continued.
Awesome, and we have a lot of questions flowing in now, so we'll try to get through all of them in the last 8 minutes here. This is one for Matt. In terms of the COVID-19 risk assessment for screening, how do you avoid false positives that could actually increase anxiety? How do you make sure that hopefully doesn't happen?
Yeah. I mean, a lot of it comes down to messaging. And what we're really working on is, when somebody does identify positive through that assessment, is to make sure that they understand that the majority of these cases are mild, and setting that standard, but that it's also really, really important that they remain at home until they speak with a care provider, because it might not be about them. It could be about spreading it to others. So really just working on the messaging that we use when someone does come up positive. And certainly making sure, again, kind of coming back to, oftentimes these people are going to be anxious because they're already worried that they already have coronavirus, right? They're probably not taking this screening because they think they're negative at that point. So giving them those resources, making sure they know where to go, is probably the most important thing that we can do.
Yeah, and I think from a messaging piece too, I mean, screening positive for going to get being screened is different than saying, you're going to take this online test and now you have, we've confirmed you have coronavirus, right? Saying you're at higher risk, you
Right.
should get screened. So I agree. The messaging piece, I think, is really important. Another question that came up related to this is, what about engagement? It's great to have all these resources on there. It's great to have, these modules built out. but do people actually use them, and what's the reception been?
Yeah, this is probably what gets me the most excited and out of the bed in the morning is that this is the piece we're so good at, is the engagement piece. The great thing about us and NeuroFlow is that's what we always keep in mind, right? So the designers we bring in are not from the healthcare. They're from consumer products that live and breathe engagement. So we have a lot of techniques that we use, particularly working with the nudge unit at Penn, in order to increase that engagement numbers. So, we're finding that 73% of our patients are engaged after that first month, completing on average like 28 activities, which could be things like self-reporting outcomes, completing assessments, watching videos, and doing activities. So I have to say, as far as engagement goes, that's one piece that we have done tremendously well, not just with coronavirus, but whether it be depression or sleep or the type of content we're able to deliver.
Yeah, and I know I've heard some from our customer success team who works on the front lines with our clinical partners, the coronavirus content specifically, they've been really appreciative of, because they have, like I said, they have these patients coming in asking them about it, and before having these resources didn't necessarily have something to point them to. So I know some of that reception's been good as well. I have another question here around, does NeuroFlow provide their own video platform, or do they integrate into the clinic's existing video solution, be that Zoom or Epic? So I can answer that briefly. So we complement those telehealth solutions. There's actually not a direct integration that's required. Really, what we are there for is to help with the ongoing assessment and remote engagement of these patients. So whatever telehealth solution you use, we compare with, and we also have done quite a bit of research to support our clinical partners in terms of what the best solution might be for them. We don't have any financial arrangements with any of them. This is just so that we can be a resource. So if you don't currently have a telehealth solution and you're saying, I need to get video set up for my practice, and you're not necessarily looking at the big sort of American Well, Teladoc, Doctor on Demand type programs, we've done quite a bit of research there and can share some of what we found and what may be the best fit for your practice. So I think since we're coming up on time here, we're going to start wrapping up. I'll open the floor to Matt and Dr. C for any closing remarks.
Yeah, I'll just start and I'll reiterate that really find those sources of truth. Make sure that when you see news articles and things come out, that you don't take them at their word, and that you look at what is the underlying sources that they're referring to. Always go back to CDC, WHO, and reputable academic medical centers through this time, because there's going to be a lot of misinformation out. And when we can understand and track and identify these trends, we can best prepare for them as clinicians.
That's great, Matt. And so I would leave the listeners to this webinar with a couple of thoughts. One is that we're early in this game. There is a lot more that will happen that we'll know about COVID-19, about how to appropriately treat COVID-19. We are now in phase 1 trials for the vaccine. I'm hopeful that will continue to progress. Unfortunately, both SARS and MERS, the previous coronaviruses back in 2003, 2012, respectively, the vaccines for those did not get past phase 1 for a couple of different reasons. So we're really early in this process. And as we see how other countries have successfully managed COVID-19, from the extremes of South Korea to now Italy, and in different ways that we do this, I think everyone in the healthcare system is going to be living day by day. And it's just, I guess, so it's okay to make mistakes. It's okay to try to figure things out and reach out to folks. I appreciate the time in speaking with you, Matt and Adam, today. I think it's important for organizations to continue to reach out with each other and offer their different areas of expertise, because only together we're able to sort of fight this, what is really going to define our current generation. Hopefully we'll never have a World War III, but this is about as close as we're going to get to a significant impact on society for decades to come. So thank you for your time, and don't forget to wash your hands.
Thank you all.
Thanks, Dr. C. So we'll, again, share out materials from this webinar. Thanks for coming, for participating, sending in questions. Feel free to visit the site that you see on the screen, or contact any of us directly, and we're happy to be a resource however we can. So thanks, everyone.